Good afternoon.
Tavish, you can start the streaming.
Yeah. So should I start?
Just ma'am, I'll just give us a couple of
How
seconds.
many delegates are there?
Ma'am, I'll
joined
just
in?
tell you once we start. So let
Okay.
me let me just ask the technical team to start. Uh, Ma'am, we can start. It's being
Yeah. Sure. Good afternoon, friends. I welcome you all to this interesting webinar of expert. We have very important talks today and the eminent speakers as well. Now I invite our president, Dr. Rashmi Mehta, to take over from here.
Hello, good afternoon, everybody, and a very warm welcome to today's webinar on chest medicine. At the outset, I would like to thank Dr. Jayesh Lele sir, who is the program coordinator. He will be joining us in a few minutes, as well as Dr. Manish Verma from Spirent, who has been instrumental in having this webinar with us. This is the second webinar with them this year. We had one more in June, as well as we had a couple of webinars with them last year also. As everybody knows, Indian Medical Association Mumbai West Branch is an expert in having CME, continuing medical education talks. We lead in having maximum number of scientific programs every year amongst all IMAs in the country. And our CMEs are all about education, medical education and teaching. We are in the middle of Teachers' Day week. 5th September was Teachers' Day. And IMA Mumbai West respects teachers in a big way. And there are two activities that we do related to teachers. One is felicitation of medical teachers, which we will be doing at our branch on 14th September this year, Sunday. Another flagship program is the Medical Scholarship and Textbook Scholarship Program, which is again related to teaching of medical education, in which from the year 2010-11, our branch has been giving medical scholarships to deserving but economically weak students of 3rd MBBS, plus textbooks to students of 1st and 2nd MBBS. To 2nd MBBS students, we give them textbooks of both the 2nd and 3rd years simultaneously. So it is a very proud achievement. We feel very proud that we are doing this activity. And as part of Teachers' Day initiative, we always do this program along with felicitating our medical teachers. I am very thankful to the speakers for today, Dr. Kinjal Modi and Dr. Arvind Gongane, who agreed for this important topic without much dilly-dallying. Very readily they agreed. And I am thankful to our secretary, our faculty, Dr. Bhavika and Dr. Shaleen, who will be joining, as well as Dr. Bhavna Patel. Special thanks to our observer for today, Dr. Ushma Mashru. And now we should start this chest update. I would like to invite Dr. Bhavika Otchandani, our AMS branch chapter honorary secretary, to introduce the first speaker, Dr. Kinjal Modi. Over to you, Dr. Bhavika.
Thank you, Dr. Rashmi. Good afternoon, friends. It's my privilege to introduce Dr. Kinjal Modi. Dr. Kinjal Modi is a consultant pulmonologist at PD Hinduja Hospital, Suchak Hospital, Pritike Asia Malad, Apex and Lotus Group of Hospitals. He's also a special medical consultant at Bhagwati Hospital. Dr. Modi has done his MD, DNB, FCCB, EDARM, PGDHHM at Symbiosis. He's also a law graduate. He has done his LLB from Mumbai University and he's currently pursuing LLM in business law. Dr. Modi has multiple national and international publications to his credit. In addition, he is a marathon runner, a singer, a poet, and a YouTuber. No, today he will not be singing, but he will be teaching us about COPD management and their guidelines. Welcome, Dr. Modi. I'll just check.
Call him? Should I call him?
I'm just trying. I'm unable to call him.
I'll try.
Dr. Kinjal?
Dr. Kinjal, you're on mute. You can unmute yourself. I think
He
his
had some difficulty in
network issue.
sharing. He had some difficulty in screen sharing. That is what he told me when I spoke to him.
I think his network is patchy because he'll have to off his video and screen share.
Hello, am I audible now?
Yes.
Yeah.
Yeah,
Yes.
you're audible, Dr. Kinjal.
Just starting the screen share and basically that is, yeah.
Dr. Kinjal, you have logged in from your phone or laptop?
Phone. I have laptop also, but I'm trying with the phone only.
Because your screen sharing is so you're trying to share it from the laptop,
It's come
the
start.
screen.
Now it comes start recording and start sharing the screen. And
So now you have
moment
to
doing the start it is not happening. That's why.
click on share and then screen share, complete screen share, and then open the PPT.
I'm logging from another phone, I think. So let me try that way.
Ma'am, till we sort this out, can we start with
Second talk?
Yeah, I think Gogan sir ka pehla le lo chalega. That's okay. Yeah.
Maybe somebody can
Now we can
introduce
share.
Dr.
No, see, this is my presentation seen now?
Yes,
Yeah,
yes,
yeah,
but
yeah.
not
Sir,
full
आपका दिख रहा
screen.
है. चलेगा सर, आप ही चलो
No,
चलो.
no, I also tried. I will leave it because I also wanted to test. That's all.
अरविंद सर पहले आप ही खत्म कर लो. That's okay, no issues. मैं बाद में ही लेता हूँ.
Should I?
Good afternoon,
In that case,
everyone.
Dr. Shalin Soni is there. Dr. Shalin, if you can
Yes,
say a
I'm
few
there.
words to introduce Dr. Bongane.
Yes. So I'm driving. Kindly excuse me for that. But I'm very happy to introduce Gongane sir. He's a physician par excellence, having done his MD medicine in 1987. He's been practicing since last 38 years. And he has his own setup at Sai Surbi Nursing Home, Malad West, Mumbai. And he has been active at association level with being president of Malad Medical as well as Goregaon Medical Association. And he's going to take us through an overview of lower respiratory tract infections today. So we are all eager to hear him. Welcome, sir.
Is the first slide with you?
Yes,
Yes,
you
yes,
can
we
make
can
it.
see that.
Yeah, we
Yes.
can see very well.
Perfect. That's
Yeah,
fine.
perfect, sir.
Thank you. Thank you. Sorry, where it is gone now? Now I change the view, I think. It should come. What should it be?
It's fine now. The first slide is fine, so you can just click
No,
on the
no, but
next.
I can't see my own
Lower
slide.
respiratory tract, the first slide.
That is all right.
Okay.
I think I changed some views. So long since we didn't do the
Yeah, a long time, yes.
online.
On the right, just put the speaker view also now. So then you'll have the
On the
speaker.
right, say speaker view.
Yeah.
Okay, fine. Now is my slide there?
Yes, it's there.
Yeah, it's visible, Doctor.
But I don't see that. That's a problem.
Then just stop sharing and reshare.
Okay.
Then you'll be able to
Stop
see.
share.
Dr. Arvind, you can just do an alt tab, alt plus tab. So I think you will be able to
Alt
share,
tab.
see your
Okay.
slides.
Let's see. I tried again. Is it?
It's just getting low.
It's there?
Yes, it's there.
Okay, fine.
Yeah.
So, good afternoon, everybody, and thanks for giving me this opportunity. I'm not a chest physician, I'm just a physician, but very much concerned with the respiratory infections that we see nowadays. And the season is so bad that every case comes with fever. We are alarmed with such things. So let us discuss today with some lower respiratory tract infections. How do I forward now?
So just click on the right, the arrow, right icon.
Yeah, I did. It is not.
Or down.
No.
A slide share. Is it going to slideshow?
I did that, but it is on the first slide only.
Yeah, it's on the first slide.
The down arrow is not working, Dr. Arvind?
Pardon?
The down arrow is not working?
No, down arrow and
Yeah.
Yes,
Now
Yes, it's done.
Okay,
Yeah.
fine. Right. Sorry for that. Lower respiratory tract infections would involve infections in the airways and lung parenchyma. It includes pneumonias, acute bronchitis, bronchiolitis, influenza, and pertussis. We called it whooping cough earlier. LITI often require medical attention due to the severity. Sometimes such cases become so severe that you really need to shift them in an ICU and treat. The global burden is huge. The figures are 488.9 million cases and 2.4 million deaths. Incidence rate about 6,295 per lakh and mortality 34 per lakh. These are the global pictures. And for India, on the right-hand side, the incidence is almost double, 11,862 it is. And we are among the three global leaders having lower respiratory tract infections. Incidentally, good thing after COVID vaccination is that the overall incidence has reduced globally. The mortality also has reduced. Influenza episodes now are reduced by 60% and the death by 72%. RSV cases are also reduced by 63% and the deaths also. That is a very fortunate thing because it has cross immunity so that the other cases also are down. LITR remains a leading global killer, especially in India. Wait a minute, I want to just remove this somehow. No, that goes off my screen. Oh yes, fine. Especially in India, children below 5 and elderly above 70 are the dominating cases that we see. And the mortality also is very much high in them. So in these groups, we are very much alerted by such cases whenever it is. I'm sorry, why it is that? No, my slide is not going ahead.
So just put the icon on the slide, the arrow, and then click on the right. on the right side. Maybe that double click.
No. No.
You have to stop sharing and then reshare, I think.
I think it was, these are my slides. So I click on that only. Okay. Yeah, fine. So amongst the risk groups, apart from the age that we just discussed, immunocompromised hosts with HIV, chemotherapy, or post-transplant patients are the ones which to be watched. Comorbidities along with that, with asthma, COPD, diabetes, cardiovascular diseases, you have more of concern. Males have higher incidence and mortality versus females. Adults over 70, as I already said, because they are frail, weaker immunity, and high mortality. Children less than 5 years, highest mortality. This is the main concern of today's talk. So many environmental and socioeconomic risk factors we are concerned, like tobacco smoke, extreme temperatures, poor sanitation, lack of hand washing facilities, then commercializations with some demographic pictures as well. Signs and symptoms of LITI: sneezing, sore throat, cough, headache, feeling unwell, muscle aches, dyspnea, and fever. So with fever, any of these symptoms, and we are alarmed, we at least have to look for the respiratory infections. Etiology are two basic differentiation between viral and bacterial. Viral infections like influenza A and B, respiratory syncytial virus, human metapneumovirus, varicella zoster, adenovirus, rhinovirus, and corona also is still there. Bacterial infections like Streptococcus, Haemophilus influenzae, we know, Staphylococcus, Klebsiella, Enterobacteria, and some anaerobes. Some atypical organisms are commonly more troubling: Mycoplasma pneumonia, Legionella, Chlamydophila, and Bordetella. Some fungal infections in basically immunocompromised host: Pneumocystis, Cryptococcus, Aspergillus, Blastomyces, Coccidioides, and Histoplasma. So differentiation between acute bronchitis and pneumonia. Acute bronchitis or bronchiolitis is present infection at the level of bronchi and bronchioles, and pneumonia is when it is an alveolar infection. Classification we do for pneumonia, basically two: nosocomial and community acquired. Nosocomial is one which is related to hospital, either hospital acquired pneumonia or ventilator associated pneumonias. It occurs 48 hours after hospital admission till 7 days after discharge. And it occurs in ICU patients or on those who are on mechanical ventilation more than 48 hours. And community acquired infection is which occurs in the community by and large. So clinical scenarios according to the likely pathogens, when it is an immunocompetent host: Streptococcus pneumonia, Mycoplasma, Legionella, influenza, SARS, and Pseudomonas, or tuberculosis also. When it is immunocompromised host with diabetes or transplant or steroids or chemotherapy or HIV like patients, it is milidiosis, tuberculosis, pneumocystis, aspergillus molds, and CMV. Broad spectrum antibiotic exposure, if at all somebody is on with so many antibiotics already taken, then you have drug resistant cases like MRSA or Pseudomonas. If it is aspiration, then probably it is polymicrobial, because it is a mixed infection with anaerobes also. Post-operatively, there is aspiration risk or premature extubation time. Then it is often a chemical pneumonitis. Antibiotics may be initiated, may be withheld at that time. Community acquired pneumonia, the common pathogens are Streptococcus and H. influenzae, Mycoplasma, or other viruses. The clinical picture is same, with fever, cough which is productive, pleuritic chest pain, and fatigue. Elderly may show atypical or less pronounced symptoms. Diagnosis is basically on X-ray, which is a standard thing, and CT chest. Then in labs, you do WBC count, which is high, then CRP or procalcitonin will be tested. Whereas nosocomial infection, nosocomial pneumonia, which is in the hospital, it is comprising of healthcare associated pneumonia, hospital acquired pneumonia, ventilator associated pneumonias. Now, these are all hospital related. So probably the patient is well under supervision. So it is kind of easy. The common pathogens are little different. Pseudomonas, the severe varieties, Klebsiella, Acinetobacter, and Enterobacter. Gram positives are with MRSA. That is the common with ICU infections, and Enterococcus. Fungal infections like Candida are seen in immunocompromised host. Then the clinical features are either that you have new fever or worsening fever, leukocytosis either or leukopenia, purulent respiratory secretions, worsening oxygenation or increased ventilatory needs, in which you can see newer or increasing lung infiltrates on X-ray chest. We have to make cultures. So you have cultures either with bronchoscopy, the biomarkers otherwise are CRP and procalcitonin or S-term 1. Gram staining is useful for simple sample adequacy if you have enough sample, but it is not definitive because then you have to go again for cultures. Imaging, no gold standard. Chest X-ray findings can be non-specific with other diseases. You have to distinguish between a new infection and a chronic one. Biomarkers like C-reactive protein and procalcitonin are important. C-reactive protein is a acute phase reactant elevated in bacterial infections. See, less than 20, we don't use antibiotic. Between 20 and 100, still we have to assess and see the increase in titer. More than 100 is a severe infection. So naturally, antibiotics, whichever you choose accordingly, are required. Mild range value, mid-range values between the two are inconclusive, in which you can decide according to the progress of the case. Procalcitonin, on the other hand, rises early, 2 to 4 hours in bacterial infections. It peaks at 24 to 48 hours. Useful to guide antibiotic therapy, initiation and duration. Meta-analysis by which you can reduce mortality and reduce the antibiotic use when you use precisely. Less than 0.10, it is strongly not given. Then in between is up to 0.5, and above 0.5, it is strongly encouraged to give. Pathogen identification is with either invasive or non-invasive sputum collection. You can collect only the sputum or swabs, and invasive is by bronchoalveolar lavage or thoracocentesis with protected specimen brush. Limitations are colonization versus true infection. So you can have some other infections along with. Conventional methods are culture, which is a gold standard, induces susceptibility testing, but it is slow because it takes time to come. So maybe you start late with a perfect antibiotic. Rapid diagnosis is, there are some newer tests with PCR or NAT. Even urine antigen test is a quick test within 1 hour for salmonella, pneumonia and legionella. Emerging tools like metagenomic sequences are also available now. So many X-ray pictures are there with pneumonias. We have to differentiate between lobar pneumonia or diffuse or multifocal, or there is atelectasis or reticular signs. You have to distinguish and then progressively see the improvement or deterioration. In adult patient, the differential diagnosis would be for some extrapulmonary infections like infective endocarditis, liver abscess, heart failures, cancers, interstitial lung diseases, eosinophilic pneumonia, or pulmonary embolism. There is earlier it was CURB 65 score. Now it is DSCRB 65 severity criteria. D means comorbidities like failure, heart failure, renal, liver, neurologic, or malignancy. SpO2 less than 90. Confusion. R for respiratory rate more than 30. B for blood pressure lower than 90. And 65 is age above 65. These risk factors are predictive of either our aggressiveness of treatment and even the prognosis and mortality. Approach to pneumonia in adult patients. Once you suspect, first you see the differential diagnosis, which is not there, then risk stratify according to the DSCRP65 score. Treat the pathogen related. So if it is bacteria, including tuberculosis or virus or fungal, then you have to treat accordingly. Then prompt source of control. So you have to control with empyema, lung abscess or extrapulmonary. Then provide organ support like hemodynamics, check on hemodynamics, respiratory system and renal system, and treat the comorbidity as well. Antimicrobial use in pneumonia. Initially, we give empirical treatment with some antibiotic of your choice, which has been prevalently given over a period. That is, first line therapy for community acquired pneumonia is either some beta-lactam or microlide combination, which is good. It covers atypical also, like Mycoplasma chlamydia. In severe cases like Klebsiella or influenza cases, this is the first line of therapy. Then in special situations like COVID-19, if at all you diagnose, antibiotics are not required. In aspiration also, antibiotics are withheld for mild cases. High TB burden countries like India, that we avoid fluoroquinolones because the resistance may develop and we need them for drug-resistant tuberculosis cases. And we have to assess with sputum culture either and chest X-ray. Immunocompromised patients, you have to specially consider and treat accordingly. Steroid use in pneumonia. Steroids are used in refractory septic shock patients when the infection is severe. IV hydrocortisone, it speeds the resolution of shock. Pneumocystis pneumonia, either with HIV, then prednisolone, we taper from 40 to 40 QD, then 20 over 21 days. COVID-19 pneumonia requiring oxygen and ventilation, dexamethasone 6 milligram, less than 10 days, which reduce mortality. ARDS.
સ્ટોપ તો થોડી સમજ નથી પડતી મને આમાં.
તારામાં તે ઓન કરી દે, હું સાંભળું તો ખરી.
Pardon?
ઓન જ છે અત્યારે.
તારામાં ક્યાં ઓન છે?
મારામાં શું કામ ઓન કરવું છે?
Manoj bhai.
CGT માં જાય એટલે
Okay. ARDS cases, dexamethasone 20 milligram, then 10 milligram, and which also reduces mortality. Let's talk about acute bronchitis and bronchiolitis. Completing pneumonia, we switch on to bronchitis, which is an inflammation of the bronchi, whereas bronchiolitis is an inflammation of the smaller airways, that is bronchioles, affecting infants. So now this is an entirely separate zone for children. 1/3 of the children develop bronchiolitis in first 2 years, leading cause of hospital admission in infants. Even the mortality, hospitalization rates have increased from 1% to 3% over a period. Acute bronchitis is caused basically by viruses, influenza, rhino, adeno, and by bacteria as well, Mycoplasma chlamydia. Bronchiolitis in infant is caused most commonly by RSV type A and B. Bronchiolitis risk factors like in infants, premature birth, tobacco smoke exposure, and immune disorders. Diagnosis is clinical, basically by history and examination. X-ray lab test not routinely needed. Testing viral PCR or immunofluorescence for severe hospitalized cases. Management is supportive for oxygenation, hydration, and minimal handling. VG bronchitis, we give short-acting beta-2 agonist first line. Severe recurrent cases, inhale corticosteroids, antibiotics, bronchodilators, corticosteroids not recommended for bronchiolitis. Pathophysiology of bronchiolitis. Respiratory syncytial virus infects type 1 alveolar pneumocytes. It gives edema and mucus production, neutrophilic infiltration, atelectasis, hypoxemia, and hypercapnia, increased work of breathing, clinical presentation with rhinorrhea, cough, wheezing, tachypnea, increased work of breathing. The child becomes very irritable. Severe and red flag signs, very important, are poor feeding, dehydration, which adds to the trouble, cyanosis, apnea, lethargy, or signs of impending respiratory collapse. So now these are the danger cases. which you should either admit or take a proper treatment protocol. Clinical course of viral bronchitis, again a repetition slide it is, so we skip this. Management of bronchiolitis in children is supportive care is the mainstay. As I said, we have to monitor the symptoms and then examine. Oxygen therapy if the SpO2 goes down. Maintain hydration either oral by or IV fluids if the oral intake is very poor. Breastfeeding should be continued as far as possible. Then pharmacologically, beta-2 agonists like salbutamol, which generally is ineffective, so then others are given. 3% hypertonic saline may improve mucus clearance so that the mucus is removed fast. Steroids, ipratropium, theophylline, caffeine, they are also are not very well proved effects. Ribavirin has limited role only in the immunocompromised children. Advance, if suppose case is really bad in admitted, then CPAP, high flow nasal cannula with high flow nasal cannula, mechanical ventilation may be required. Prevention with paliviruzumab, passive immunization for high risk infants. No effective RSV vaccine yet. Antivirals are also under research, so not really to be used. Bronchiolitis prevention is with RSV vaccine given to pregnant women 24 to 36 weeks to protect the infants. Nirsevimab, long-acting monoclonal antibody, it is just mentioned, I don't know about it. Paliviruzumab, still used for high-risk infants. Management of recurrent LRTIs in children, reassurance and reassessment. Most otherwise healthy children need only reassurance. Arrange follow-up if doubts about health status and recurrent symptoms. You have to find out another causes of why recurrence. Antibiotic use, we have to avoid basically multiple short antibiotic courses without clear diagnosis. That has been the mistake that many people, even the parents start off with antibiotic which is given last time, and even the general practitioners also would give. So there are many antibiotic courses already taken partially or otherwise, and they become resistant later on. Overuse will give relief. High relapse rate is there and resistant risk is always there. If protracted bacterial bronchitis is suspected, 2 weeks trial of Comox is a good answer. In distinguishing from asthma, in young children where lung infection test not feasible, it is therapeutic. You have to assess and then find out when the child comes repeatedly. Antibiotic therapy for children LRTIs, if it is community acquired, we give amoxicillin first line, amoxicillin orally or otherwise on severe cases, ceftriaxone. Atypical community acquired, the organisms are Mycoplasma, pneumonia and chlamydia. There we give clarithromycin and azithromycin as well. If suppose it is by swallowing or inhalation pneumonia, the organisms are strep pneumoniae and we give amoxiclav or ceftriaxone IV if needed. Bronchiolitis, it is mainly virus. So no antibiotics and only supportive care. Even for bronchitis, the same thing. When we see pulmonary infiltrates in immunocompromised patients, we have to, with suspicion of pneumonia, we have to do sputum, blood and urine cultures, chest X-ray and CT scan. We have to localize the infiltrate. If it is a localized infiltrate, then empirical antibiotic, same as for other patients of pneumonia. If it is MRSA, it is separate. Strep pneumonia, severe cases, consider with higher investigations for other organisms. Reassess within 3 days. If it improves, good. If no response, you have to go on with the other tests available. Diffuse infiltrate, you have to do bronchoalveolar lavage and start empiric antibiotics. Then localize the exact organism. Severe illness, consider PJP, CMV. Reassess after 3 days. And if there is no response, consider SLB. Thank you. I have to stop here, I think. Yeah. Over to you, Bhavika.
Yeah, Rashmi.
Thank you, sir. Yeah, good. Thank you. And that was a very, very interesting talk. I think Lele sir has joined us. Good afternoon, Dr. Lele sir.
Yeah, good afternoon.
Sir, we'll take the question answer at the end together.
Yes, yes.
Yeah. So, may we have introduced the next speaker, Dr. Kinjal Modi. Maybe Dr. Kinjal Modi is able to do screen sharing. Dr. Kinjal?
Yes, madam. Yeah.
Dr. Kinjal is going to speak on COPD.
You facing any technical difficulty, Dr. Kinjal?
Presently, I am share screen has started, right?
So once you share screen, you clicked on the
No,
icon, then you have
text tab.
to, sorry, or
Just a second. क्या दिख रहा है इसमें शेयर करने से
Dr. Kinjal, otherwise what we can do is we can do the screen sharing and you can just speak
that's
about
fine.
the,
Please,
I think that
grateful.
would.
Yeah, that
Perfectly fine.
works then best.
Yeah, no issues. Please, sorry, I tried a lot of time basically for not able to connect it. Sorry.
Just give me 1 sec. I'm just getting the
Sure,
presentation.
okay. Yeah, just at the onset, basically, I'd like to thank IMA, Rashmi Madam, Lele Sir, Arvind Sir, and all the people who are there who made this thing possible for all of us. Basically, people like to take sandwiches in the breakfast, लेकिन मेरे लिए lunch में हो गया because two stalwarts, Lele Sir and Arvind Sir के बीच में मेरे को मैडम ने डाल दिया कि भाई किंजल आपको लेक्चर देना है दोनों stalwarts के बीच में. Arvind Sir, as usual, is fantastic. The talk was really very nice and very informative to me also basically to go through the LRTI once again as a warm-up session for me. I think so my screens are being there. Yeah, fantastic. Thank you so much.
So, Dr. Kinjal, you can start.
So I think so you can go to next hospital and we don't have any sponsors or to any disclaimer from our side. Basically, it is all on a webinar basically managed by IMA. Next slide, please. Mr. Manish, thanks a lot. Yeah. So flow basically of the event will be like very simple one that we have an introduction to start with a few things what COPD is and how the COPD behaves and why it is there. So maybe basic pathophysiology followed by that. Then we have a diagnosing part of the COPD. Generally, we are all aware how to diagnose the things. Management in a bit detail, and then a follow-up of the patient. A case study also we have time permits. We can continue with the same. And lastly, we have taken some take-home messages. So basically, starting with the next slide, please. COPD, as we always have nowadays we have a habit of having some kind of data to be given to the people that we understand why we are discussing COPD. But to understand one simple thing is that when we discuss COPD, we should understand that it is the third leading cause of death. First leading cause of death, everyone knows cardiac. Second is CVAs, other means brain, all those things. So basically, third is COPD, which unfortunately no one knows it. A few years back, it was actually second leading cause of death. So basically, unfortunately, we have a huge chunk of COPD patients, and they are contributing to the largest mortality rates of the world. But unfortunately, we pay less attention to either diagnosis and the treatment of the same. That is why we are there to discuss this lecture today, and so that we can have some few pickup points so that basically we can diagnose it in time and basically treat it also in time. So global deaths is 3 million death. Unfortunately, we lose 3 million COPD patients every year, and annual death rate is, we can say, 4.5 million by 2060. So within next 35-40 years, the death rate is going to double the what is that presently, and 90% of this is under 70 years. Generally nowadays we say 70 years is a quite productive age group. 70, 75 above, we have senior citizen age group also nowadays above 85, and all these people who are happily living their life. But people are losing their life because of a small problem, it is COPD, and which is generally related to smoking and other obnoxious stimuli also, which is part and parcel of life, which we discuss in the pathophysiology later in the later slides. And household air pollution is also one of the major risk factors nowadays, with unfortunately, because of which COPD is coming up. Next slide, please. Thank you. So just to start with the COPD, how it goes about is, so it is basically a respiratory disease of the airways. So we knows that we want to travel from one destination to another destination. Suppose I want to travel from my place to IMA. So basically the whole road probably to reach the IMA should be cleared for me. So if I'm able to reach in time and to be there basically in toto, my car reaches over there in time. So basically for that, there should be road should be clear, there should be no obstacles, there should be no accidents. So basically, so that it's not narrowed at any point of time. But unfortunately, suppose some bridge is under construction, or basically there is some narrowing, there's water logging somewhere. So then basically the road becomes narrow, and then it is a problem. So the airways are like roads. The oxygen from the atmosphere goes to the blood vessels through these roads, right? So basically, these roads, if they are fit and fine, nothing required, no discussion of COPD required at all. But because of some obnoxious stimuli, there is unfortunately chronic respiratory symptoms like dyspnea, cough, sputum production, and maybe some associated with exacerbations also. And these abnormalities are generally bronchitis or bronchitis, something I think bronchitis, Dr. Arvind sir already told in the previous lecture. And apart from that, basically there is alveoli is also affected in form of emphysema. The structural changes are generally persistent, and that is why this is a not always a reversible airway disease. So in the airway disease, we have two simple in terms on the averagely, if you want to understand. Next slide, in meanwhile you can put it, please. That basically there are two things. One is irreversible airway disease, which generally asthma side. The second is the non-reversible, basically the COPD side. Just to basically understand two things. Next slide, please. Hello. Next slide, please. Yeah, thank you. So basically, the Dr. Manish, whoever is doing the slide change, just let him be aware. Moment I say, you can just slide with the earliest. Thank you so much. We can see the time. The main condition of COPD, we understand that we have two basically entities collected together and basically called as COPD. COPD is chronic obstructive pulmonary disease. Some people call it lung disease also. COLD is also one term used. But initially, long time back, there were two separate diseases: emphysema and chronic bronchitis. Chronic bronchitis is basically the airway inflammation, chronic mucus production, and the patient coughing of sputum again and again. They were called as blue bloaters in the earlier lifetime. In the earlier books, it was mentioned that way. And now emphysema basically is basically the airway, the air sacs. You can see in the photo, and basically that that the air alveoli, which is the last unit of the lung, get dilated because of air trapping inside, and unfortunately because of structural changes they get damaged and become huge enough, and that is not being used. That is basically the air getting collected over there. The air is not getting exchanged in that area. So unfortunately that is the emphysema part of it. This is pink for first. Okay. Yeah. Thank you. So previous slide was mentioning something about India, how it was there. Now it is the symptoms of COPD. So basically, the symptoms of COPD are generally starting with shortness of breath, chronic cough, wheezing, chest tightness, and fatigue. Depending on what the patient has, patient might not have all the symptoms, maybe one or two sometimes. The combination can vary depending on the patient presentation. Next slide, please. Hello. Yeah, thank you. So causes and risk factors of COPD, basically, if we want to understand is lung damage, inflammation, smoking is generally the one of the most common cause till date, even if we have found various other causes of COPD, but smoking still remains the major cause of smoking of COPD. And COPD many times I have discussed on the live platforms also that basically smoking, it is not always that what we are, person who is smoking himself is getting affected. No, person who is a passive smoker also is affected. Now, the definition of passive smoker, people don't, a person only understand that suppose I'm a smoker, I go outside the room, come back, speak to you, and I have not smoked in front of you, right? And you go to your home and meet your wife, or you meet your husband. So basically, if it is that, then the smoke which I had smoked outside the room get conveyed to you, and you go to and give to your spouse. That is a level of passive smoking. So people think that if I am not standing in front of my friend who is smoking, I am safe. No. If you have a smoker friends, so basically going to have the effect. So basically, be careful by letting your friends. It is not in our hands, but unfortunately, be careful. So next is workplace exposures are also basically unfortunately harmful because their chemicals and dust particles and industrial chemicals, pollutants basically have the effect on the lungs and affect the person and lead to COPD. Air pollution is a huge topic by itself. We can discuss for hours together for this, but yeah, in short, indoor and outdoor, both air pollutions are affecting the lungs and giving the lungs a tough time to breathe into this atmosphere. Genetics basically play definitely role over here. Alpha antitrypsin and the topoisomerase, basically if it is absent basic in that kind of patient, the pan-acinar emphysema is commonly found in those kind of patients. Genetically conditions are definitely affected. Next is alpha antitrypsin deficiency that has the role. Screen sharing has stopped, I think so. Hello. Yeah, thank you. So basically, next slide, please. Yeah. So basically, pathophysiology features of COPD. This is a bit of boring things, but yeah, just to make you understand, very simple way that airway obstruction and air trapping because of the airway disease, the airways get constricted. So the volume of air which is remaining behind is not able to get out. That is air trapped inside the alveoli, and that is damaging the alveoli also. And it is less elastic recoil, and unfortunately, that is why the we can say the airway disease, small airway disease come up. Next is hyperinflation, is one of the again pathological features of COPD, and dyspnea, basically excess tolerance, and respiratory failure, and all those things comes up because of all those issues. Next is pulmonary hypertension is one of the associated factor very with COPD because simultaneously the pulmonary circulation also has the remodulation and become constricted. That is hyperplasia. That is why there is a more pressure the lung heart has to apply. It leads to the pulmonary hypertension. Exacerbations basically are the infections and pollutants and all those things, and the gas trapping basically inside the things, and unfortunately decreased VQ mismatch. Basically, the more of air inside and little less of blood, or less of blood and more of air. Either of them basically leads to hypoxemia, and if it is very severe, it is hypercapnia. That is the more of carbon dioxide inside the blood also is possible because then the more of air is not able to go out of the lungs. Unfortunately, that carbon dioxide also remains in the blood. So that is why the hypercapnia, it is very severe stage. It is type 2 respiratory failure. It is only hypoxia, type 1 respiratory failure. So basically, it is also associated with the COPD. Next slide, please. Yeah, so there's few definitions which basically COPD has been easily been managed according to the something called as GOLD guidelines. It is Global Initiative for Obstructive Airway Disease Management, and this is the association which is working for us. I think so, 13, 14 years now. 2009 or 10, the first guideline came up, and then every year the new guideline comes up, and those are followed all across the globe. So they have brought some new definitions just to get more patients inside the COPD and early diagnosis COPD can be done. So there's something called early COPD. It is an early beginning of disease, difficult to identify the onset of it. It's gradually, so we don't have all the symptoms, but yeah, maybe PFT showing some kind of changes or that kind of things are definitely there. Mild COPD is that depends on the airway obstruction. Basically, we discuss in the next few slides. Next is young COPD is generally the COPD occurs at the earlier days we have diagnosed COPD only after 40 years of age, but nowadays young COPD is also occurring. So that is what that subset also brought in the definition. Pre-COPD is where the airway symptoms, basic structural changes have occurred, but there is no obstruction at present. So we can see the some CT scans, some changes have occurred, but there is present a PFT parameter is normal. So effect is yet going to come. So basically the function is still normal, but structure changes are there. So pre-COPD. And prism is basically preserved ratio, but there is a received FEV1. So basically FEV1 is it is a one within 1 second whatever amount of air coming out, it should be generally 80% or more. If it is less, and the ratio, that is FEV1 by FEC, that is because of the ratio, which is the obstruction is there or not, which is a spirometrical value, which basically we decide the obstruction is there or not. So if it is normal but there is a reduced FEV1, that is called prism. That is a uh, uh, preserved ratio, but basically there is a FEV1 is reduced. Next slide, please. Yeah, thank you. So basically, now we come to some kind of diagnosis. So as we know, there are generally the three, four things. One is the clinical part, and one is the non-clinical part. So clinical part history is very important. So here we have to understand that basically we have clinical symptoms, and we have chest examination, smoking history, BMI, family history, lung problems, not other comorbidities all simultaneously. Next comes is basically we have to see the spirometer. That is, we have to ask the patient to blow in the spirometer and find what is the level of spirometer and what the level of lung function is. X-ray helps in seeing the hyperinflation or complication diagnosis, and the blood test generally we do to see that any other associated anemia or erythrocytosis or other alpha antitrypsin deficiency, basically if it is there, to diagnose all those cause as well as the effect of the COPD in this. Next slide, please. Yeah, so COPD further test, if we go in further, that we have ECG, as I know that basically for pulmonary hypertension and cardiac related events, basically we have to see whether the cardiac part is involved or not. So ECG 2D helps in that. Peak can be used in a routine patient for COPD, but generally it is more helpful in the rest of patients. But yeah, for a COPD also patient can keep a track of his function, no harming that. Pulse oximeter is a handy tool nowadays. So basically saturation and pulse both are monitored over there. CT scans are helpful in the initial diagnosis part of it, and yeah, taking in infective phases, when taking the phlegm basically of the patient to see what kind of infection patient is having through, which Dr. Bhuvan has just spoken to us. Next slide, please. So now, just to inculcate how to manage and how to go about the patient of COPD, there's something called as ABCD rule given by global guidelines. So initially it was ABCD and E was exacerbation, but then they found that C and D basically are almost the same, and basically it was similar to the B part of it. So basically also make a difference of management in the C and D category. So basically they moved. So now there are only three categories A, B, and E. So basically, what does that mean is it is on the right corner. But before going that, we just have to understand that the left hand side, if we start, is we have to diagnose patient with COPD with the help of a spirometer, and then basically there is the assessment of that we can see that is a 20, sorry, 80, 50, 30 rule. Worldwide, 80, 50, uh, 30 years. Uh, milliliter ratio, which is less than point, as parametric part of COPD. Coming to the exacerbations and clinical features and the symptomatology, all put together, then comes the ABCD. So how that all three are coming together. So now there's MMRC guide, that is the walking, basically modified. Basically, it is a breathing scale that if a patient is breathless, the MMRC guidelines are telling us that basically if the patient is able to walk for a couple of distance and having breathless. So 1 and 2 is breathless only on, so 0 and 1 is only on the breathless on climbing a few steps above. So it is a kind of exertion which is on the higher side. Only on that condition patient is breathless, then it is fine. Or basically 2 and above means patient is able to breathless and walking few steps, or walking someone else is being behind. So all those things basically when it is there, it is a higher stage of the dyspnea. And CAT scoring is the COPD assessment testing basically, which is again a scale of 24 or 25 points. And if its scores are less than 10, it's a better scoring. So it is good that less symptoms, less sputum analysis, and less phlegm is coming, less breathlessness, patient is fine. But if it is more, then basically it is a CAT more than 10 or above, then it is on the B side. So A and B are very simple to understand. More symptoms and less symptoms. So more symptoms is B, less symptoms is A. Now, if there's exacerbation, one or more exacerbation, or a hospitalization, one hospitalization, then it is considered as E. So these are the basic understanding about the exacerbations and all those things. Less than 2 exacerbations, 1 or 0 exacerbations, then can be taken as A or B, either of them. So there's a whole understanding of the COPD management point of view. So A, B, and E. If you understand only one slide, this one, while going back today, really good, great for me. It's a difficult slide to understand, but that's to understand is it's less symptoms, less exacerbations, minimum treatment. More symptoms, maybe exacerbations sometimes, some for more treatment. And if it's a higher exacerbation, that is E category or hospitalization, then more treatment. That is what basic to understand. Next slide, please. Yeah. So this is the same thing I discussed in the previous slide only. So we can skip this one. Next slide, please. Right. So other comorbidity conditions, because COPD is not a single disease of lungs. It is a generally said to be systemic disease, which affects the heart in the form of pulmonary hypertension. Many times arrhythmias also come up with this kind of patient. There is cardiac events, myocardial infarction, stroke, and severe deaths also are occurring with this. Cardiac failures are many times associated. Peripheral artery disease, that is unfortunately a part and parcel of COPD. Lung cancers are also there, along with osteoporosis or sarcopenia. Both are basically part and parcel of the COPD perspective. And sometimes this depression, anxiety also are there together. And GRD is also one of the factors which is generally as a part as a comorbid condition of the COPD. Next slide, please. So basically, now coming to the goals and principles of COPD treatment. Primary goals and receiving symptoms and preventing exacerbations, identify and reducing the risk factors and exposures. Basically, smoking cessation intervention should be actively pursued in all the patients with COPD. Evidence there is generally we have to ask the patient to stop the exposures to the smoking and other related events like indoor biomass exposure, which is called as indoor pollutions, that should be avoided. And clinician can avoid basically returns whatever best you can do. So there are various evidence level, but best is if you know there is a return to a patient environmental, try to avoid as much as possible. That is the best thing, that the patient can avoid the exacerbation and can be a better breathing environment to the patient. That is the best thing we can do. Pharmacologically also we can help it, but yeah, generally it is going to help it. But more avoiding the means the exposure to this kind of risk factors will be very helpful. Next slide, please. So now various medicines which can be generally used in this kind of the COPD is a long list is there. So we are just the midway, so I'll be a bit faster. So basically, that management, basically diagnosis has been done. Now we have a review of symptoms which has been done. Basically, pharmacological adjustment, non-pharmacological management has to be coupled with that simultaneously. As I told you, that vaccinations discussed by Dr. Gungane also, but vaccinations are very, very helpful to prevent exacerbations in COPD patients. Smoking cessation is very helpful. Active lifestyle and exercises, pulmonary rehab is a part of it. It's very helpful in the case of COPD patients. And self-management of education is very helpful for these patients in many comorbid conditions. And initial assessment, as I already discussed in the previous slides, that the assessment has to be done and management has to be done and review has to be gone. So the basically cycle is going on continuously, assessment continuously, and basically we go on patient that every time we need to see that patient is doing better. If they're doing better, we can slowly reduce the medicines if possible, or if they're not, they're worsening, if they're, then we'll increase the medicines. Next slide, please. Yeah, so basically, as I told you, the A, B, and E groups, whatever mota groups, whatever is there. So I think it's better wasting time over here. We go to the next slide. It's just tell you the better way. Next slide, please. So that is showing the, yeah. So basically, that was the initial part slide I told you we would remember today. So there's A, B, and E. So basically, the lower part, lower left corner. If it's A, the basically patient less symptoms, less exacerbations, less problems. Basically, only one bronchodilator, single bronchodilator, either a LAMA or a LABA. Basically, can be used. What is LAMA and LABA? LABA is long-acting beta 2 agonist, and LAMA is long-acting muscarinic antagonist. Antagonist is basically various medicines like diatropium bromide we know, and long-acting basically we indaclinium, nowadays ubiquinum, new medicines we have been coming up. So basically all these medicines are long-acting muscarinic antagonists, and LABAs are basically many Valentrol, formoterol. The other medicines basically are the long-acting. Sametrol earlier it was there, so they are long-acting beta 2 agonists. So generally, when there's only one group, LAMA is preferred generally, and when we have more symptoms and some more exacerbations also, then two combination, the two medicines has to be used. With the inhaler, both the medicines are combined, great for us. Otherwise, two separate inhalers can be given. Not always prefer single inhalers if the patient is happy with that. So now both of them are done. But now suppose patient is exacerbation many a times, and basically that patient is definitely requiring combination. And if the blood eosinophils counts are more than 300, the new guidelines even show it more than 100, then we can use ICS, it is inhaled cigarettes. Now you can understand that in asthma, initial management start with ICS, but in COPD it comes towards the end just to prevent exacerbation and when they have then the severe stage. Initial part COPD we never give ICS because generally when ICS is not required, it's been shown that they can increase the chances of pneumonia and respiratory infections, which Dr. Gungane was enlightened us. So all those things are very high if you're giving ICS without requiring COPD. But in exacerbations, if they are there, any eosinophil counts, blood eosinophil counts are more than 300, and definitely they are useful. Next slide, please. I think 5 to 7 minutes more, and then I think we'll wrap it up. Next is the follow-up of pharmacological things. We understand that if dyspnea is going down slowly, if it is increasing or decreasing, depending on that, we have to decrease the medicines. So now the dyspnea, as we can start with one of the either of LAMA or LABA, and if it is more, then we can use both of them. And technique is also very important. Checking the technique also is very important because many times we just write the prescribe the patients, give for particular medicines, and then patient are taking medicines wrongly. I have many times myself seen the patient even swallowing the capsules of the trans caps, that is rota caps. So because that was just mentioned on the discharge card that Foracort 200 or so and so the medicine for rota caps morning evening. So they thought it is like other tablets, it is swallow. So unfortunately, the technique is very important, and we need to understand that patient that basically that these are the things to be taken care of. Next slide, please. Yeah, so basically management of patient with ICS we also has to understand without asthma features has to be well controlled on NABA LAMA and contagion therapy is acceptable. Otherwise, generally, if there is no asthma-like symptoms because there is an overlap of asthma and COPD maintained of course or something like that, that is also possible. That is we can use it. Next is some exacerbation if it is there, as I told you, and let us say this eosinophils, we already discussed it with more than 100, also ICS can be used. With less than 100, then ICS should be avoided. That is what basically thing is. In major symptoms, modified symptoms, again ICS can be added plus minus depending on the response to ICS earlier. Next slide, please. Yeah. So this is very important. Again, one more important slide which you should remember while going back today. Said apart from medicines, can we do something else for asthma? Yes, we can. So basically, those are the things we should understand and how to be behind it. As I told, first is smoking or cessation for smoking or any exposing factor. Basically, patient is affected. Next is basically physical activity is very helpful in this kind of patients, and vaccinations. Basically, let's see, the group of patient is A, B, or E. All three has similar things only. The only thing we have to persist, the patient is more easily convinced when it is B and E and less with A, because they think it is less symptoms, less exacerbations. So then we're not very much easily convinced with A, but yeah, slowly they are understanding and they do the things. Next is basically the vaccinations are very helpful. Whether it is influenza vaccine, pneumococcal vaccines, pertussis, shingles, and RSV vaccinations. RSV is just to come in India. It is not yet there, but it is basically will come in sometime. Other vaccines are definitely available in India, and if possible, if the patient is affording, definitely should be given to all the patients. Thank you so much. Next for that. Next slide. Now, other things what is generally helpful is but when they follow up for the non-following part, what we have to actually do is, if the response is appropriate, the maintain things and annual influence and all those things. Self-education is very important. Behavioral changes like smoking and exposure things have to be reduced. Basically, exercise program, as I told you, rehab program is very helpful in COPD patients. They have given a wonderful results for the patients and symptom control. If there's no target is not achieved, then basically we have other things for the patients, and provide rehab program and our exacerbations and whatever best we can do. We should put the predominant trial, predominant trait, whatever basically what they are following, either the dysmic ones or the exacerbation ones, and depending on that, basically we can manage them accordingly. The written action plans for either of them. Next slide, please. Right. The Pulmonary Rehab is a fantastic program, basically, which is a comprehensive program. It is a 12 weeks program, which is precise training, education, self-management, and behavioral changes. Goals, basically, we all know that basically we need to understand the patient needs to improve his symptoms, and with the help of bronchodilators, we are able to dilate at some point of time, but not everyone. So basically, the patient has to understand the lung capacity is limited, but they have to do a lot of work. So body has to get used to the lungs doing less work. So in simple words, when I explain to a patient is, when a person is earning, suppose he is earning 50,000 per month, but when he's retired, suppose he is earning 20,000 per month or 15,000 per month. So life doesn't stop there. No? What we do generally is that we restrict our extra expenses, and when we spend in the judicious way. So that's the same thing. When the lungs are limited in capacity, then we have to use the lung in a judicious manner, so that basically the extra effort which is taken up by the muscles and all those things, the muscles get trained to be working on a low oxygen content. So that is what the whole thing is about in the exercise training, so that the basically body gets used to the small oxygen which is given by the our COPD affected lung, and that is why the patient can lead a less symptom uh, life. So basically, so it can not be 100% symptom free, but at least less symptoms are there. So basically, less breathless with the same amount of walking what was doing earlier. So that is very helpful, and patients are very happy with this. So they are definitely indicated for the group B and group E definitely, but every group helps, and it is a structured program, and basically older population, all population can be taken. Next slide, please. So self-management, again, it's very great thing. That basically, it's, most of the things I already told you, that patient has to be motivated and engaging uh, uh, in the health behaviors and manage the super daily. They should be given a chart how to do it, how to manage their own COPD, the techniques how to be checked. We can have a foundation of people around the same skills and can help in participating in the activities, and education basically helps to improve the skills, and behavioral changes, that's the most important thing is required in this kind of self-management groups. Next slide, please. Right. So cases, I think so we'll skip for some time. Just we can lastly go to the take-home messages. Last slide directly, because I think so a lot of time is already gone. Discussion takes a lot of time. Next slide, last slide. Take-home messages. Next. The 3-4 scheme. Yeah. Please keep it off. So the investigation was done. That was the same thing. Patient what I have done basically, it has discussed the same thing as done for this patient and what a treatment was given. So basically the same thing as I mentioned and what are the things to prevent this kind of patient. So that was the thing. Last, yeah, the patient discussion is there. Last time, the next time, next one. Yeah, thanks. Just wait for a second. So basically, last but not the least, we want to again understand that COPD is the third leading cause of death, and so please you have to pay attention on it and diagnose it in time with the small knowledge whatever we have and with spirometries and other technicalities, technical investigation what we have with us, and try to avoid pollution either inside or outside. Moment we are diagnosed with group wise, group A, B, and E, treat them accordingly. Primary prevention is always very helpful, but smoking cessation and secondary prevention will also be very great. Whatever moment of time person smokes or stop smoking is very going to be definitely helpful. And yeah, spirometry when the patient is stable or initially when the patient is not stable, every 2 3 3 months spirometry has to be done to assess the condition. And once patient stabilizes, an spirometry and the walking test and saturation being checked and imaging and pulmonary rehab and exercise and group and association everything are very helpful. So that was from my end. Thank you so much.
Thank you, Dr. Kinjal and Dr. Arvind Gungane. They both have done the great job of explaining the lower respiratory tract infections as well as Dr. Kinjal talked on the COPD. I have received a lot of questions from the chat box. Manish, can we have both the speakers on a single form? Can
Yes,
you
sir.
spotlight them? Yeah, please. Yeah. Before we go on to the questions which we have received from the delegates, as a family physician, first I would like to ask the questions to the Dr. Arvind Gungane. One question, basically, regarding then the same question in extended format. Let Dr. Kinjal answer this particular question which I am trying to ask you. See, basically, what happens is, as a family physician, I'm giving you all this thing that many times the infection, lower respiratory infection, the patient comes with a visa, elderly patient with some comorbidities, maybe diabetes, maybe blood pressure, and here and there. And second thing, he is a breathless. Number one. So it will be in the moment first as a first send it to the consulting physician because I feel that it's a respiratory tract infection. But then subsequently, I may have to refer the same patient to the chest physician because that's what I want to understand, that which patient should go to the respiratory physician directly or which patient can be handled at the consulting physician level. So the basic question is that he may be having exacerbations of the asthma, he may be having exacerbation of the COPD, or he may be having breathlessness with little wheeze and any particularly area with a consolidation or kind of a lower respiratory. So I think first let Dr. Arvind Gungane give something input, and then I think Dr. Kinjal you will be taking over. So Dr. Arvind, your choice first. Over to you, Dr. Arvind.
Yes, sir. Sir, I feel first of all that all such patients should be first with Dr. Lele, the family physician, number one, because no, because because of your experience, number one, plus you know the patient from the beginning. So you know whether he's been diagnosed as asthmatic or COPD earlier. For me, every patient is new. Number one. Number two, all such patients are at risk of getting infected very often, right? With whatever reasons plus the season, maybe in the monsoon time. In that case, fever will be on top priority. Fever with productive sputum, which you always can detect infection as a cause. Added on to asthma or COPD, let it be. But at that moment, you only would treat them with infection or without infection, antibiotic choice is the main concern of everybody. So Dr. Amdekar used to tell us for pediatrics that never start antibiotic till 5 days, and we used to get scared. Same thing Dr. Ramamurthy said for COPD patients, don't start antibiotics. It is not digested because the relatives will be forcing you to do that. So you are the one to direct the patient either to a physician or chest physician. We'll accept it happily.
Kinjal, your
Yes, sir.
input.
So basically, as Arvind sir nicely told that, Leela sir, that when a experienced family practitioner, which is actually a rarity nowadays, if we have around, it's great for us. So diagnosing the patient, number one is 2 3 points, as a most of thing Arvind sir has told. I just say point wise. Number one, first is either faking the symptoms or real symptoms. That only can be picked up easily by a family practitioner because he knows him. उसकी नस उसको पता है कि सच बोल रहा है गलत बोल रहा है. Number one point. Number two, if it is genuinely a respiratory problem, then giving a small treatment or doing a simple X-ray and checking a saturation. These 3 4 things are very helpful. Saturation, if it is low, then definitely it makes sense to refer the patient immediately, because then we don't have to waste the time in managing the patient over there. Anything below 80, below 92 definitely has to be referral at the earliest. Number two, if the patient not able to breathe, means speak properly, if he's able to not say, Lele sir, my name is Kinjal Modi, so that is okay. But if he says, Lele sir, mera naam Kinjal, so that is you, while first time you understand he's genuinely breathless. So that kind of patient, again referral. So basically either a good physician or chest physician, that is a different matter. But that person has to be referred in time. That is one other thing. Other routine patient who is coming to you with a simple viral exacerbation, which is very common nowadays. So basically that can be treated with small bronchodilators, some syrups, some antihistaminics, and basic investigation to see if it is infective or no. Then go ahead with that is definitely important. So otherwise, if it is non-infective, which is a viral one, giving antibiotics of no use.
My question to, of course, both the panelists taken anytime, I mean, answer this thing. How do the latest Goal 2025 guidelines redefine the role of triple therapy in COPD patients with frequent exacerbations? Yeah.
Right.
Over
So
to you,
actually, I
Kinjal.
just So basically, I just answer it, sir, because though Gongane sir, वो chest patient के बाप है, because उनकी बेटी chest patient है, but at present I'm there. So basically, just to get things very sorted and easily get it out. So basically, COPD has been easily managed by GOLD guidelines, sir, and the new person, as I told you, A, B, and E. So when it is E or E category, when basically the patient is having more symptoms, exacerbations, history of hospitalization is definitely there, then that kind of patients have to prevent it further hospitalization stay. So triple therapy is LAMA, LABA, and ICS. All three has to be taken in this kind of patient. But only thing pinch of salt is that eosinophil count in the blood should be more than at least 100. So that is what the things are. So that is they are accepting is at in a single inhaler for the same thing as nowadays available. So patient is very happy taking one inhaler with all the three medicines, and access control as well as the prevention of exacerbation is very nice with them. They're definitely helpful, sir.
Dr. Arvind, you want to add anything?
No, he's a master.
Yeah. What are the key clinical markers that should drive decision making between LABA stroke LAMA versus LABA and ICS combinations? These two combinations nowadays we see frequently. So what will be the role separated out for each of the combinations?
Sir, ICS itself has basically a role in COPD in a later stage just to prevent the exacerbation. It does not have a stage in stage A and B. ICS generally does not have a role. So we have to understand that either we are managing asthma or COPD. So that we have to be very careful and understand, because when a patient comes to a general practitioner, or if it's first time going to a physician also, basically if the test parameter is not done, we are not 100% sure, because history can be either side, because some asthmatic patients are having allergic symptoms, and along with the smoking history also, and some smokers have allergic symptoms also. So exact book picture is never existing in front of us. So after doing this parameter, when you understand it is a reversible disease or the non-reversible one, even reversible, giving them ICS is of no use. Definitely can be helpful and definitely can be given for a long time, and slowly with the improvement of the lung function reduce the medications. But if it is only pure COPD and stage is either A or B, then ICS is not required. In higher staging, when exacerbations are more, it is 2 or more, or patient is hospitalized once because of all these issues, then it makes sense to use ICS to prevent the further exacerbation and further hospitalization in that cases. That is the role of ICS in COPD.
What will be the role of biologics evolving in COPD management in future 5 to 10 years?
I
Of
was
course, it's a
expecting.
costly therapy, is very costly, but
I know,
then
sir. I was expecting that question, sir. We have a variety of nowadays of many times we speak of this MABs. I always remember this Sri Lankan team always. श्रीलंकन टीम में हर एक के नाम स्पेल करना बहुत मुश्किल होता है अपने लिए मुरलीधरन एक याद है कि बाकी सबके नाम बहुत अलग अलग है so that is what we have various groups of biologicals available nowadays targeting different enzymes and different immunoglobulins at various levels. Okay, so basically it is very helpful, no doubt about it, but thing is cost is definitely issue. Second is before going to biologicals, nowadays in the recent guidelines also and the recent international discussion what we had recently also, people don't recommend it on day one because we expect in future that when COPD is diagnosed, we can just target that enzyme or basically that the inflammatory factor and can treat the COPD in the basic cause by itself. That is what the future might be. But presently, when the treatment, optimal treatment, pharmacologic and a non-pharmacological management is completely done, patient is not responding to either of them. Patient is very symptomatic after that also. Then at those patients, we generally offer basically of biologicals, and biologicals generally are the cost goes in lakhs. So basically, it is generally a lifelong therapy. So it is not that दो तीन dose लिया खत्म हो गया. No. So there are schedules for everyone. Some is monthly start with, some are 3 months to start with. But at the end of the day, they have to continue it for a long time. So that is what the biologicals are there in the picture. Definitely are good. Nothing wrong in that. Initially we had only one or two, but nowadays we have plenty of them. But you have to use them with wisdom. That's the only thing. So thank you.
Given now everybody is talking about the AMR, antimicrobial resistance, especially rampant use of antibiotics in every cold cough, everybody gets some antibiotic, or maybe time it is that they have already consumed, looking at their past experiences, that last time doctor had given me this, so let me try
That
this
always
and
we
all
discussed.
those things. So given the thought, we are talking about the antimicrobial, but then since as you both physicians, consultant physician and respiratory physicians, we are facing more and more challenges on antimicrobial. So how would you give short points for the family physician to address to this issue, especially for the long-term use of antibiotic, and whenever needed, whenever to avoid, and all, at least you both can give me some input.
Yeah, sir, Dr. Kinjal, I'll give you the initial remark and you then
Yeah, please, sir.
give the final word. Sir, what I feel, even at my level or at your level, for any patient for that matter, by the time you assess the patient, you know that he is how severe is the disease, right? So for minor cases, better to wait and stop, as the seniors have taught us. So better not to start. And till my level also, I always feel that I should start the smallest possible antibiotic available to me. So not to jump on to the higher ones immediately, because I don't know the response of the smaller one can be good and enough for the patient. And once he is crossing the limit and not getting nicely controlled, by the time I refer to Kinjal, he should have a chance to hike up the antibiotic accordingly. By the time, because we even don't do the cultures or higher test, we depend on WBC as well as maybe CRP or calcitonin. Like procalcitonin levels, looking at that, okay, the urgency of antibiotic, you start the basic standard goals. For my matter, it is amoxicillin to kind of be happy about, not to go any higher up. And unless that happens and the case is beyond, probably a chest physician will take over. Now, Kinjal, your job.
Sir, yes, you answered the question very nicely, sir. Just a very simple thing when I remember that basically the COPD exacerbations or infection, basically, I always remember my microbiologist, sir. So he always used to say, okay, organisms basically are distributed very easily. So positive ones are above, negative ones are below. So basically, for respiratory, generally positive organisms, gram-positive organisms are more culprit. So giving amoxicillin, as you said, very fantastic, is good antibiotics. Or even doxycycline. Even guidelines also say that you need to start with the doxycycline, which is a age-old forgotten medicine, but basically fantastic antibiotics which works till date. So basically, are the very nice drugs. Even erythromycin. Azithromycin basically I'm not preferring nowadays because most of the time it is done study in Hinduja as well as in Nair Hospital years back. 50% of Mumbai population is resistant to azithromycin. So basically, just same group, if you can go to clarithromycin, it's a better option. So that is again the good antibiotic to start with. But if we are suspecting an exacerbation, sending a sputum culture simultaneously is very helpful, and then starting the antibiotics because even one dose of antibiotic goes and then sending the sputum sample doesn't make any sense. So ask the patient to send the sample, and once moment sample is sent, start the antibiotic, come with the report to me. If the sputum shows fantastic report is that medicine is working, my work is done. If they are not working, then basically then I would understand, oh, it is not working, I have to change that. Simple thing. Sometimes they should not be able to produce sputum, then we have nowadays biofire available very easily. So we can have the throat swab, what we have done earlier. So nowadays we have throat swab for the about 20 bacteria and 20 viruses basically. So the whole bacteria and viruses purview is available within 12 to 14 hours in our hand, that what exacerbation or what infection patient is having, and we can treat accordingly. So this is the way the weekend exacerbation can be done, sir.
Uh, Friends, now we are talking about the antibiotics, everything. But as you know, everybody is talking about the various vaccinations. So, especially as a these two, both the group as a respiratory comorbid and COPD patients would require a proper vaccination in the form of influenza, pneumococcal, and if anything else is there. So there is a little confusion about the pneumococcal vaccines because every somebody says, oh no, it is to be repeated after 5 years. Somebody said, no, no, once you have taken this now, now next year you take another, and now another vaccine has come, and only the numbers are different. So please simplify and tell us that how to go about this. And of course, I will request Dr. Bhavika, Shalin, if they have any questions, so be ready with their questions also. So over to you for the vaccine thing. Yeah.
So if you can answer very, very quickly and simply, sir. Hello, yeah, I'm audible. Yeah. So basically, sir, pneumococcal vaccine. Presently there are three types of pneumococcal vaccines: 13, 20, and 23. Okay, but let's discuss 13 and 23 first because they are available since a long time. 20 has just come in the market. I speak that something about that later. So 13 छोटा फिगर है तो पहले वो देने का है. उसके 23, the 13 and 23, basically the 13 and 23 के बीच में we have to give a gap of 2 months minimum. Gap can be more than 2 months but not less than 2 months. So 23 पहले देने का और sorry 13 पहले देने का, 23 बाद में देने का. Simple to understand. Suppose a patient has taken 23 पहले से ले लिया है उसने, तो that patient has to be given 13 after 1 year. Right? So that is basic to understand to start with. Now, how long to continue? 13 is lifelong. Once given, not to be repeated. 23 till the age of 65, you have to repeat every 5 years. If the symptomatology of the patient is basically in that age group, every 5 years you would repeat. After 65 years, again, that is once a lifetime. So a person coming to you, if the patient age is above 65, Previnar, that is the 13 we have given, 2 months later, 23 we have given, Khatam, pneumococcal is over. But just to add on one more thing, influenza has to be taken every year lifelong, sir. Usme there is no stopping in the medication because every year the WHO finds new virus strain and that is what new thing coming up. Now, lastly, something about 20. So 20, to stop this confusion between both of them, the company has brought up with the 20 variant one. So it is only again a once a lifetime one, and it has to be taken only one injection. That is what company is promoting at present. But the cost at present is a bit on the higher side. So giving it to all the patient is a bit difficult. But yeah, if the patient is taking only 20, then only one vaccine is required and it is lifelong. It is been recommended. They don't ask to repeat it again after 5 years or something. 20 is not to be repeated. So 13, 23, 20. They all three are there available and easy to understand, sir.
Dr. Gungane, regarding the influenza, there is always, we have been talking to the patient. They say, no, this is northern hemisphere, this is southern hemisphere. So can you just add the little touch on the northern and the southern hemisphere? Yeah, please.
No, in fact, I am not aware of this. I skipped the question to Kinjal.
ठीक है sir. No issue, sir. I'm there today. So basically, there are two type of variants which generally come up. Certain variant generally comes in in the month of last week of March and April. Basically, with every year WHO brings that time, and the northern variant comes somewhere in September, October. That is this time generally is brought in the market. So there are two variants which WHO recommends and has been there every year comes out. Northern hemisphere, though India falls in northern hemisphere, but depending on the climatic conditions, Jammu Kashmir is only considered in the northern hemisphere. Below Jammu and Kashmir, everything is southern hemisphere. So basically, Mumbai, everywhere we are in southern hemisphere. So we have to follow southern hemisphere guidelines. That is basically we have to take the vaccine in the last week of March or April when it comes at that time. We have to continue that. Some patients who definitely are very much exacerbating, which they have a good number of exacerbations, in spite of taking influenza vaccine in the March also, they might be recommended a northern hemisphere strain when it comes in the month of September end or October. But that is a very small cliched group of patients. Generally, once a year for this kind of patient is sufficient enough. For even for medical practitioners also, sir, it's very helpful that if we all of us take the vaccination at once a year, it's very great effective for us.
So why I'm asking this question about the northern and the southern hemisphere is that many times what happens is this is not particularly for the older population or anybody, young college students going to the USA. They have you must have seen lot of list of the this thing, and then it is written that this vaccine should be taken, that vaccine should be taken. So, like somebody staying in India going to the USA, India, of course, USA, there is a variety of the temperatures across the entire US. So, would you recommend any this vaccine for the influenza vaccine? The rest, of course, they have charted down. So, would you recommend influenza vaccine to the such a student going to the America?
Yes, sir. Why not? Basically, but that will be northern hemisphere also, because that basically with North America falls northern hemisphere. And
Correct.
exactly which state, if you know particularly, we can depending on the state, because every state has different guidelines over there. So we can ask them very exactly are going. Let us know the guidelines, and accordingly we can give it. It's always better to vaccinate the patients. Better.
I think Bhavika, Dr. Rashmi, Shalin, if you have any
Yeah.
questions, please put in.
Yes. So, Dr. Kinjal, my question is to you. A lot of family physicians visit patients with BiPAP and home oxygen, right? So, what will be the oxygen level which should be maintained in COPDs, and which are the red flag signs where they should refer?
Right. So the patient is on COPD, is on BiPAP and oxygen therapy. That means that the patient is type 2 respiratory failure. That we understand. Type 2 respiratory failure means that patient is having less of oxygen and more of carbon dioxide in the blood, just to make people understand. So to modify those things, the BiPAP is given so that this CO2 can be slowly reduced with the help of the supporting the respiratory muscles, and so that the easily washout of carbon dioxide can be done. Oxygen is given because hypoxia is there, because BiPAP machine cannot give oxygen. So oxygen is supplemented simultaneously in a small matter. Just before answering the question further, I will also like to tell there's something called as in-between thing that's called Venturi mask, which most of people across the many people are not even aware of that something called Venturi mask, because that is a thing which can be easily used in a home also as well as hospital, and it serves the purpose of BiPAP as well as the oxygen thing simultaneously can be given, because in COPD patient we have to give less of oxygen, right? Because more the oxygen we give, more the carbon dioxide is formed. So what we are targeting the saturation is that 88 to 92 saturation is perfectly fine. 90 plus minus 2. So that is fine enough, because moment to try to increase saturation from above 92, the more oxygen produced will be converted to carbon dioxide, and that is again the BiPAP has to remove it off. So 88 to 92 is a perfect combination which is there. Less than 88, then we have to increase the oxygen again. So that is the key way we have to understand. For home, we can give a lever till 85 also, but not less than that. That is the basic saturation gap, or we can range we are looking for.
And what is the role of low dose morphine in COPD patients? And when will you start the low dose morphine?
Madam, some people towards the end lifestyle, because COPD is never a reversible disease 100%. So when we know that patient is bad COPD and is not going to come out, and basically if they suppose they are ventilator, generally avoid them going on ventilator, because we know that the reversal is very difficult in this generally the lung themselves are affected. If there is exacerbation, as Dr. Gungani sir said, definitely can reverse and come back. But unfortunately, if there's bad lung, then generally we avoid. And this kind of patient towards the end of this life, because breathlessness, that kind of feeling what the patient has, he's not able to breathe in spite of able to breathe, but the lungs are totally full. So that kind of things, unfortunately, patient has to pain relief kind of can be done, and that for that purpose it is given. Thank you for the question.
Thank you. Thank you.
Charlene, Dr. Rashmi, you have anything?
No, sir. Very lucid presentation and absolute clarity for all of us to operate our police.
Yeah, over to Dr. Rashmi.
Yeah. If there are no more questions, then I would like to invite our Joint Secretary, IMA Mumbai West, Dr. Bhavna Patel, to give an official vote of thanks. Bhavna, madam, over to you.
A very good evening to one and all attending today's webinar. I feel honored to do this pleasant duty of vote of thanks. I sincerely thank Dr. Manish Verma from Spirent, Delhi, our moderator Dr. Jayesh Lele sir, Trustee IMA, past HSG, our two esteemed speakers, Consulting Physician Dr. Arvind Gungane, Pulmonologist Dr. Kinjal Modi sir, for sparing their valuable time, imparting us very good information and useful knowledge on the topic of chest management, COPD, and the respiratory tract infection, which is really the need of the time, that is the monsoon season. I'm deeply thankful to our President, Dr. Rashmi Mehta, and the entire organizing team for arranging this webinar. My big thank you to you all, the attendees, and my office staff for being here and giving us the time to learn so many things. And I'm so thankful to Dr. Jayesh Lele sir, who has raised the topic of antibiotics and also the vaccination, which is the prophylaxis, and even to take care of our students who are going to US to study further. Thank you so much. Thank you.
I also thank special thanks to Dr. Manish Verma, because he is the instrumental and he is depending and he is giving us the opportunity. Last year also we had a similar seminar. This year also webinar, and I look forward to Dr. Manish to have more and more occasions to this kind of programs. Thank you, Manish, and the entire
That is so
Pirate
nice.
team. Yeah.
That is so nice of you, sir. On behalf of Parent, also, we like to thank IMA Mumbai West Branch for this excellent session of cough expert webinar. I would also like to thank the speakers, Dr. Kinjal Modi and Dr. Arvind Gongane, for their valuable expertise, and definitely Dr. Jayesh Lele and Dr. Rashmi, who have been instrumental in getting all the things together for this excellent webinar. I'll also like to thank Dr. Bhavika, Dr. Bhavna, Dr. Shaleen, and Dr. Madhuwala for the contributions. It has been a wonderful session, sir, and we look forward to doing many more with
Sure.
you.
Thank you. Thank you so much.
Thank you. Thank you, Dr. Manish. Thank you,
Yeah.
everybody.
Thank you so much.
Yeah,
Thank
bye-bye.
you. Thank you, madam.
Good day.
Sorry
Good
for
day.
technical glitch, but it was finally a fantastic lecture. Thank you
No,
so
sir,
much.
it,
Thank you.
it was absolutely good, Dr. Modi.
Thank you,
everyone.
Thank you.
Bye-bye.
Thank you. Bye.
कोई सर्दी हुआ है
लेले सर ने मैसेज बोला कि किंजल का आवाज बराबर नहीं, बोला सर किंजल को लैरिंजाइटिस हुआ है।